So in this video we are going to discuss about the 2025 ERS or ATS classification on interstitial pneumonias. So this is the update replacing the 2013 guidelines. So initially the 2025 what it is going to mandate is the progressive pulmonary fibrosis response to antifibrotic regardless of the underlying diagnosis. So necessitating a focus on disease behavior over strict etiology. So we are going to focus here on disease behavior, then just sticking with the etiology. And outdated pathology terms are no more used in this. And the pattern trap, that is a particular imaging or a particular biopsy pattern is always should be this particular diagnosis is a pattern trap. So there can be a different pattern with a different diagnosis is what the 2025 guidelines are telling. So next is the four major pillars of 2025 update is beyond idiopathic. Always before naming idiopathic, we no longer separate idiopathic entities from the secondary causes. So whatever it is, when the fibrotic pattern comes, they are going to be the same modality of treatment with antifibrotics. The anatomical split is the main change that has happened. The no more classification of etiological classification is no more used. The preferred classification is the anatomical split, whether it is interstitial type of pneumonitis or alveolar filling pneumonitis. And terminology overhaul has been made. So there are so many changes in terminologies, especially with the three type of things. Hypersensitivity pattern is changed into bronchiole centric interstitial pneumonia, and desquamating interstitial pneumonia is made into alveolar macrophagic pneumonitis, and acute interstitial pneumonitis is made into diffuse alveolar damage. So these are the changes made in terminologies. And diagnostic confidence can be if there is strict evidences, it is more than 90%. There are no much evidences, but moderate evidences are there. It is 50 to 89, and less than 50 is considered as the lesser diagnostic confidence. So when we are diagnosing a case with ILD, we have to know how much diagnostic confidence we have. So these are the four major pillars of a 2025 update. So as we know, the 2013 terms were acute interstitial pneumonia, which has made into diffuse alveolar damage. And desquamating interstitial pneumonia is no more used. It is alveolar macrophage pneumonia. Hypersensitivity pneumonitis is never used. It is bronchiole centric interstitial pneumonitis. And again, the most important fact here is diffuse. When it comes to hypersensitivity pneumonitis, it is a multidisciplinary diagnostic, and bronchiole centric pneumonia pattern is isolated to HP now. This can be seen with CTD-ILD, aspiration, and drug toxicity also. So this is a different pattern, but it will be there in HP, but should be always not HP. That is what is the newer evidence over the new pattern. Next, coming to the evolution of Ild classification, as we saw from 2002, which was just like IPF centric approach. Now it in 2013 we made it like etiology known and etiology unknown, and like idiopathic and non-idiopathic. Now in 2025 we have brought a very good evolution of classification, that it is interstitial type or alveolar type, which is anatomical. So everything related to connective tissue, hypersensitivity pneumonitis, medication, drug toxicity, environmental, smoking, aspiration, infection, everything should be ruled out before putting someone into idiopathic diagnosis. So there are so many things to be ruled out. Aspiration infections are also considered as a risk factor for certain type of ILDs. And we don't know, even environmentally, so much pollution can also lead to ILDs. In some places like Delhi, where the pollution is very high, that could also lead to ILD. And medications is very important, as before. HP also should be ruled out. Diagnostic equation pattern is not always diagnosis, is what the new guidelines tells. Before it was like, okay, if we see something called as H-Sheath pattern, it is hypersensitivity pneumonitis. Now that H-Sheath pattern itself is coming under bronchiole-centric pneumonitis, which means that it can be HP, but it is not necessarily to be HP, it can be related to CTD related ILDs also. So morphological pattern with clinical context is the one which is very important. So for example, we have given example BIP pattern, that is the new name of HP pattern with avian antigen exposure, I will call as a HP. But BIP pattern with the serology RA positive with anti-CCCP positive is IILD. BIP pattern with exhaustive negative workup, nothing is there, then it is idiopathic BIP. So a pattern is not specific to a disease is what the new guidelines did. And anatomical division means the interstitium is involved. As we all know, the interstitium is this part and alveoli is the inner part. So the alveolar part is involved, the alveolar airspace is involved. We have certain amount of alveolar space filling pneumonitis like organizing pneumonia kind of features, while the one which are involving thickening, inflammation and progressive fibrosis of interstitium is a different pattern. So that is classified into simply interstitial consideration and alveolar consideration. Lower predominance as seen in UIP, NSIP, LIP, and upper predominance in pleuroparenchymal fibroelastosis. And diffuse is BIP and DAD, that is diffuse alveolar damage, previously known as AIP. Peripheral is UIP, NSIP, PPFE, and NSIP can be subpleural sparing. Alveolar consideration multifocal in organizing pneumonia and eosinophilic pneumonia. Diffuse in AMP, that is alveolar macrophagic pneumonitis, that is the new name given for the DIP. PAP, pulmonary alveolar proteinosis, organizing pneumonia and eosinophilic pneumonia can present like a consolidation also with GGOs, and fat attenuation in lipoid pneumonitis is everything alveolar filling pattern. So this is the broad classification as we told: interstitial pattern, alveolar filling pattern. In interstitial filling pattern, again fibrotic, non-fibrotic, acute and rare conditions. Fibrotic and non-fibrotic can be there in UIP and SIP, BIP. But in acute and rare are DAT, that is previous acute interstitial pneumonitis. Pleuroparenchymal fibroelastosis is not acute, it's a rare. And lymphocytic interstitial pneumonia is also rare. And alveolar filling is common and smoking related is common is organizing pneumonia, it is not smoking related. Smoking related will be RVILD and alveolar macrophagic pneumonitis, that is DIP. And rare ones are eosinophilic pneumonia, lipoid pneumonia and PAP. So we all know the UIP, NSIP and BIP patterns. The key changes are not made. The same thing, subpleural and paraseptal basal predominance, honeycombing with temporal and spatial heterogeneity is the histological hallmark for UIP. NSIP, lower lung predominance, frequent subpleural sparing, homogeneous GGOs with reticulation is like key HRCT hallmark. Histological hallmark will be homogeneous alveolar wall thickening. BIP, alveolar airway centric peribronchovascular mosaic attenuation or 3 density sign is now defined in BIP. Bronchiole centric fibrosis with peribronchial metaplasia and the HP histopathology is important. So these are the major changes that are made in the guidelines. Now it is going to be the usual UIP pattern, how it is defined, and the radiological definitions are explained. There are no much changes in these patterns which has been explained before also. The only changes are made something in organizing pneumonia, that's all. So UIP will be going fast with this. Radiology, we all know subpleural and basal predominant fibrosis. Hallmark is honeycombing. If honeycombing is there, don't think multiple confusions, it could be UIP. And absence of significant cyst mosaic attenuation and predominant GGOs won't be there in UIP. Histologically, there are subepithelial fibrotic foci being the hallmark. And clinical context, it is a pathological hallmark of IPF, but it doesn't mean that it is always IPF. Always rule out CTD, ILD, fibrotic HP and asbestosis. So this is that. And always remember that the honeycombing sometimes can be microcystic, sometimes it can be macrocystic honeycombing like this also. There was a rare case which I saw where the honeycombing was very big enough that there was confusion that whether it is a UIP pattern or some other cystic pattern something. So it could be macrocystic honeycombing also. So again, radiological pattern is what this is having a predominant hallmark 5 feature called honeycombing. And NSIP again radiologically lower lung predominant GGOs with reticular abnormalities. Subpleural sparing is a hallmark, but again it is seen only in 41 to 64% of cases. So subpleural sparing should not be necessarily be present. That is what lung volume loss is there when fibrosis progress. And histologically absence of honeycombing is very important. And again there will be uniform thickening of alveolar wall and rarely idiopathic NSIP will be. So before naming NSIP as idiopathic, always rule out CTD, drug toxicity, and the most common ILD in CTD ILDs are obviously NSIP, except for the rheumatoid arthritis where it is always UIP is the most common pattern. Next, coming to non-specific interstitial pneumonia is going to present like this. As we could see a very clear picture of subpleural sparing in this. So this is pleural, subpleural sparing here. We can see in this image both sides. So these are subpleural sparing. When there is a progressive fibrosis can end up like this. So that doesn't need to be always having a subpleural fibrosis. Lower lobe predominance, commonly subpleural sparing is present. With GGOs with fine reticulation, there is no honeycombing. If it's honeycombing, it is UIP, that's all. And bronchiolocentric BIP is a addition, formerly known as HP pattern. So here it is again how it will going to be present. Profusely poorly defined centrilobular nodules with GGOs with mosaic attenuation. So we all know this 3 density sign, that is a normal attenuation, hypoattenuation and hyperattenuation. Normal attenuation is the normal lung. Hypoattenuation is the area where there is going to be more blacked out. And hyperattenuation is the area where there is predominant GGOs. So this histopathologically again lymphocytic predominant inflammations are seen. Airway remodeling is present and small peribronchial granulomas is present in HP, which is strongly highly suggestive histopathologically. So again this BIP is not specific to HP. Now they tell it is related to CTILD, aspiration and inhalational exposure also. If exhaustive research reveals no exposure, it is labeled as idiopathic BIP. So this is a new thing. So this is the famous head cheese pattern. As we told, here is the normal lung, here is the hyperattenuation, and you can see here is the hypoattenuation. So these 3 things in the same lung is called as 3 density sign. And there will be peribronchial GGOs noted and centrilobular GGOs with mosaic attenuation. Mosaic attenuation is hypo and hyperattenuation, 2 things only. 3 density is going to have normal lung also is included, that's all. And granuloma is something very important here. Diffuse alveolar damage, again radiologically HRCT will have bilateral patchy GGOs with focal sparing. Dependent consolidations can be there. With early traction bronchiectasis is highly predictive of mortality. Here it is going to be hyaline membrane formation. It is like ARDS simply replaced as from AIP, and the mortality is also very high. Here we can see there is a patchy diffuse GGOs in the entire lung with significant traction bronchiectasis, architectural distortion. In a few minutes of few days or few weeks, it will progress and worsen and patient will die. Here the risk factors are going to be sepsis, aspiration pneumonia, and acute exacerbation of CTILDs can also present like a bad lung. So here it is exudative, organizing and fibrotic phases like ARDS. The pathological pattern will vary. And other rare forms of interstitial patterns are PPFA and lip. PPFA is nothing but puroparenchymal fibroelastosis. Here there is sharply demarcated dense consolidation exclusively in the upper lobe, and there is subpleural intraalveolar fibroelastatic changes. So and lip is going to be bilateral GGOs with randomly distributed thin wall cyst, and they have to rule out always some lymphocytic predominant diseases like Sjogren syndrome, HIV and dysproteinemias. So in see, when PPFA, you can see here, when Indian doctor sees this kind of CT, they can easily tell that there is some past history of tuberculosis. So again, yeah, there is a high risk of past history of tuberculosis ending up in a pleuroparenchymal fibroelastosis. Along with this, idiopathic is also possible, CTD related is also possible. And one more thing, a CTD disease which doesn't directly involve the lung but involves the chest wall is ankylosing spondylitis, where there is a the chest diameter, the EP diameter is going to be reduced because of flattening of the chest. So this also have some impact on PPFAs, what some studies tells. So again, you can see upper lobe predominance fibrosis. And this is lip, as we mentioned, we can see some numerous small cysts which are not so significant, and there is a perilymphatic predominant, and we can see predominant lymphocytes in this, and always rule out CTD and immune deficiencies. Next, coming to the alveolar filling pattern. Till now we saw the interstitial type of pattern. Alveolar filling pattern are only two, that is organizing only very less, organizing pneumonia, RBILD, and alveolar macrophagic pneumonia, that is previously known as DIP. So organizing pneumonia is nothing but polypoid plugs of loose fibroelastic connective tissues, where it is going to be patchy. It is like patchy pneumonia, that's all. It will be migratory. And here again, post-infectious drugs and CTD should be ruled out. If everything is ruled out, it is called idiopathic or cryptogenic organizing pneumonia. RBILD, it is 93% smoking related. Here there is bronchiocentric, we can see some nodules, and lightly pigmented macrophages are seen in the ball. And AMP again, here there is going to be diffuse mid and lower lobe predominant, and heavily smoking related plus dust and inhalation CTD related can also be possible. Organizing pneumonia. So here radiology, HRCT, we all know there is going to be subpleural peribronchial consolidation. It will be migrating on serial imaging. And reverse halo sign is a very important sign we will see in the organizing pneumonia. So patchy distribution with preserved lung architectures in some places are seen, and we can see the loose connective tissues filling in the alveolar duct in HP. Always rule out secondary causes before calling it a cryptogenic organizing pneumonia. And usually it is confused with the normal pneumonias, that is the problem. So when we follow up, we can see the change in the position of the pneumonia or increasing in the pattern of the pneumonia is called and a distinct reverse halo sign, atoll sign, is very important, very unique for organizing pneumonias, that's all. And this thing is new. Organizing pneumonia sub-pattern spectrum has been changed. So it was made it as cryptogenic organizing pneumonia or secondary organizing pneumonia, where there is diffuse multifocal consolidation, reverse halo sign, and migrating tendency is what we were leaning from till now. Acute fibrinous organizing pneumonia is something new, where there is fibrinous intraalveolar ball with absence of hyaline membrane. It looks almost like a mass. So mass or nodules in tendency to coalesce along the bronchiovascular bundle, but when they do biopsy, they are not having malignancy tendency. They are just having intraalveolar balls which are fibrinous. So this is also acute fibrinous organizing pneumonia. Cicatricial organizing pneumonia are the people who became fibrotic, like fibrous brands with small dense nodule, densiform ossification. Here they have reticulation in sati with the pulmonary ossifications also are seen. So calcifications are also noted in this case. So this is cicatricial organizing pneumonia and acute fibrinous organizing pneumonia, new things added. And others are RBILD and AMP. RBILD, as we know, they are poorly defined centrilobular nodules with GGOs, and always with the smokers and pigmented macrophage. Here it is primarily mid and lower and peripheral pedalation, fine reticulation, and uniform distribution of macrophages in the completely air filling spaces, previously known as DIP, highly specific to the smokers. So as we could see here, upper lobe predominant centrilobular nodules with GGOs, nodularity. This is RBIRD. This kind of pattern is very, very common. In these cases, you can do a biopsy and can see pigmented macrophages helping you with the diagnosis. Or if you are not able to do, we can tell them to do smoking cessation. This was related to your smoking. When you ruled out other things, I am telling. Alveolar macrophages pneumonia will predominantly look like GGOs, reticulations, sometimes with cyst also. So this is the second ILD we are going to speak with a cyst, then lip, after lip. Pigmented macrophages filled air spaces and diffuse distributions are present. Here it is diffuse distribution, here it is broncholar centric distribution. And other rare eosinophilic pneumonia we can easily diagnose with a bile eosinophilia, and I will resolve normalize with the steroids. Lipoid pneumonia, they have eye attenuation with minus 30 to minus 150 ounce fill unit. And pulmonary alveolar proteinosis, again there will be bile will be milky and it will also accumulate circumference due to autoantibodies. So these are the patterns which are very rare, but eosinophilic pneumonias, peripheral non-segmental consolidations. PAP, crazy pavement pattern, the famous pattern for PAP. And LP, lipoid pneumonia, high attenuation, and these things. So again, there is no need to be a single person. There can be UIP with NSIP. Always rule out CTD-ILD HP with IPF. UIP with PPFE, it can be related to IPF and CTD-ILD. NSIP with OP, CTD-ILD, post-DAD drug reactions. And BIP with AMP, again active smoker with HP, DAD with UIP, acute exacerbation of IPF. So always there should be confident diagnosis, which is usually made with classical HRCT pattern. In an old male smoker, I can tell confidently this person is having a old this thing. But provisional is, I have ruled out everything. The working diagnosis is going towards idiopathic. Okay. Unclassified is less than 50%. I couldn't get the diagnosis in spite of the whole. This thing is called as unclassified ILD. So always when we go with the ILD, we should have whether we are confident or we are provisionally diagnosing them or unclassifying them. That is very important. And always genetic telomeres testing for the familial IPF. This is a very a separate topic, can be discussed with IPF. And molecular biomarkers are tested on them. And this multi-diagnostic imaging pattern. So we are going to future is genomic translations should be done, environmental gene interface, define extract interaction between genetic and predisposition and triggers, and standardization and diversity are the next horizons which has to be dealt